Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsiders. Richard Hazel. Sorry, I got a little cold while I was abroad in Amsterdam, but we had a really good weekend. Congress. It was the second European Orthopedic and Sports Acupuncture Congress, and we had a very nice group of acupuncturists from all over, not just in Europe, and it was very good. I thought I'd give you a little recap of what you missed if you weren't able to attend. Jenny Nieders came from California. She works for the San Francisco 49ers and works on a lot of teams, some rugby teams, other teams. And she covered things like ankle sprain and Achilles tendonitis, sort of the underlying pathologies. Can be muscle imbalances, it can be proprioception, different things, and then how to address those. So that was a very interesting and excellent presentation that people really enjoyed. Josh Margolis came from California to teach about segmental dysfunction in the spine, not just segmentally neurologically, but actual physical restrictions that can affect the spinal segments movement. So rotation might be inhibited by a vertebra that has a difficult time flexing or extending on one side. So he showed us manual techniques for assessment and treatment that involved pressure as well as needles. I covered some arm and foot nerve entrapment scenarios. The first day I covered radial nerve entrapments, the radial tunnel syndrome, which is a painful forearm injury that often gets misdiagnosed as a tennis elbow. You usually can differentiate by pressing on the lateral epicondyle and into what's called the mobile wad, the extensors about 3 or 4 fingers down below the, or actually could be 2 or 3 fingers below the lateral epicondyle area. Tennis elbow usually more painful when you press on the lateral epicondyle. And then the entrapment of the posterior interosseous nerve, which is a continuation of the radial nerve once it passes through the radial tunnel and under the supinator. The supinator can entrap the posterior interosseous nerve, and then you get a weakness. So the radial tunnel is more of a pain syndrome, and the posterior interosseous nerve entrapment is more of a muscle weakness of wrist extension. And because the posterior interosseous nerve innervates the extensor carpi ulnaris and the extensor carpi radialis brevis, it will make those two weak on extension, and you'll see the wrist go into radial deviation on wrist extension because the extensor carpi radialis longus is still intact because it's innervated by the deep branch radial nerve. So we went through that assessment and treatment. And then I talked about the superficial radial nerve and its sensory components on the dorsal hand. The superficial radial nerve is entirely sensory, and it can cause pain, numbness, tingling, etc. You will see sometimes the superficial radial nerve pain being misdiagnosed as de Quervain's because it runs straight through that same area. Also, treatment of de Quervain's with injections can actually injure the superficial radial nerve, causing numbness in the dorsal hand. So I covered that and the assessment and treatment, as well as the cubital tunnel entrapment of the ulnar nerve, the entrapment of the ulnar nerve by the medial tricep, and also I covered sort of the lateral tricep entrapment of the radial nerve. We went through some differential diagnosis for neurogenic thoracic outlet syndrome and talked about segmental issues that could also cause the same problem. And then I covered de Quervain's, how to treat that. And then I did, for the second part, I did the foot neuropathy stuff, the dorsal foot numbness from the superficial peroneal nerve, and the plantar foot numbness from the tibial nerve entrapments at the tarsal tunnel, and also the tendinous arch of the soleus, about 5 fingers down below the popliteal fossa. If you press on the soleus in the back of the leg there, and there's tenderness, you should suspect that entrapment causing foot numbness, usually bottom of the foot and big toe. And Dr. Trescott will say that that's usually a double crush. So you already may have a tarsal tunnel entrapment causing numbness on the foot, on the bottom of the foot, but it will be increased if you also have a tibial nerve entrapment in the upper soleus area. So we covered that and the treatment of that. And no, it's not recorded, and no, there is no online version. COVID sort of destroyed live seminars in a way, because people now no longer want to leave their home. And so we've seen a drop in attendance in live seminars, and people seem to just want the recording. You advertise your live seminars, and people say, "Oh no, I have a wedding to go to. Was there a live recording?" COVID kind of destroyed that, destroyed the live seminar, and it's unfortunate. I guess Rothenburg, the TCM Congress, is very well known in Germany. Usually has over 1,000 attendees, and this year they only got about half of what they expected. It can't just be financial. I think people have gotten in their head that everything can be done from their computer and a Zoom meeting, and it's just not the case. Our profession relies on palpation. It relies on physical sensations, understanding palpation for pain, as well as what's behind your needle. You cannot learn to needle from a video. Now, sure, you could get the basics from a video, absolutely. But when you're treating real conditions and real problems, you actually need to be able to put your hands on a patient and be guided by somebody who is teaching what you're supposed to be feeling. If it's new material for you, you really need to be going to live courses. So unfortunately, because we did not fill our course this year, the Congress I just did, there will no longer be live seminars that are hosted in Amsterdam. So that's really, I think, a big loss for European acupuncturists, because that's been going on for over a decade, and they were always full, and people always loved it. And over time, since COVID, people stopped doing live seminars. So I think that's unfortunate. It's unfortunate for you if you never did a live seminar, because now you're going to have fewer options. And if it was because you didn't want to travel for an hour or two within Europe, now you may end up traveling to the United States because that's where live seminars are still going to be going on for this type of acupuncture, the stuff related to motor points and trigger points. That said, I will be teaching in Siena, Italy at the end of November. So if you're in my Podia courses, you'll get notification of that. It will be in English with Italian translation. So there is that. Hopefully, if you are interested in live seminars, that you'll consider coming to that. And I don't have the full outline and curriculum yet, but there will be a focus on sports performance, something that people seem to be interested in. And if you've only been taught how to treat pain, you really need to understand how to assess for someone who's not in pain to avoid injury, improve sports performance, improve stabilization, flexibility, and strength. Those are the things that we can do with orthopedic acupuncture. And if you've only been taught how to treat for dysfunction and pain, then it would behoove you to learn how to assess a healthy athlete and find what their weaknesses are, because they're not going to test weak. You need to find what is suboptimal for a professional athlete. And there are ways to do this, and it most of the time is not testing strength, because even their weak is strong. So we'll be covering stuff like that in Italy, as well as some other problems, some nerve entrapments, very likely, and some common pain syndromes that you would see with athletes and adults of many ages. So there's that. What else can I tell you? I recently was looking at some research on the Gluteus Minimus, so I was going to throw this in there. If you stayed listening this long, didn't turn off because I was complaining, then you get a little tidbits about the Gluteus Minimus. There's some cadaver studies of the Gluteus Minimus that show some variations. Some people have a Gluteus Minimus that shares fibers with either the piriformis or the superior gemellus, or both. So I thought that was very interesting. The Gluteus Minimus shares fibers on some people with two muscles that can entrap the sciatic nerve. So isn't it interesting that trigger points in the gluteus medius on some people is creating sciatic pain? Now, you can differentiate the trigger points in the gluteus minimus that create sciatic pain from sciatica because there is no numbness or weakness when it's coming from trigger points in the gluteus minimus. It's just pain that goes down the sciatic pathway. But I thought that was interesting. The gluteus minimus has two tendons. Did you know it had two tendons? If you just Google origin, insertion, and action of the gluteus minimus, you will see that the tendon inserts on the anterior portion of the greater trochanter. But did you know that it actually has a smaller tendon that goes in front of the entire joint capsule? So it's actually helping functionally stabilize the joint capsule. It is not just abduction, internal rotation, and some people would say flexion. It is actually helping to stabilize the joint capsule. So now it makes sense, doesn't it, when there's a labral tear in the hip, that the gluteus minimus is almost always injured, tight, short, painful, causing a tendinopathy. So I thought I would, throw that out there, because I only saw that on a couple different research papers. That not everybody tells you about that second smaller tendon. And some cadaver studies show that there are two parts of the gluteus minimus, an anterior and a posterior gluteus minimus. I thought that was interesting. The other thing that's worth mentioning about gluteus minimus is that it will create greater trochanteric pain syndrome, GTPS, and that often gets misdiagnosed as trochanteric bursitis. But they have found from research that trochanteric bursitis is actually much less common than they thought. And most of the time, pain on the greater trochanteric pain syndrome, is caused by a tendinopathy of the gluteus minimus and sometimes medius. Almost always minimus, sometimes medius. So that's worth noting. If you have people with pain over the greater trochanter, it's probably not bursitis. It's most likely a tendinopathy of the gluteus minimus and medius. So, and of course, I treat the TFL and the piriformis when treating those conditions, because the piriformis is the antagonist of the internal rotators, TFL, glute min, and the anterior fibers of glute medius that all internally rotate. And the TFL is the cousin of the gluteus minimus. They both abduct, internally rotate, and flex the hip. So they're doing the same work with different fiber orientation and different depths, but they're both doing pretty much the same thing. So TFL and gluteus minimus should be treated at the same time. Now, gluteus medius also tends to be the strong abductor that's weak, causing the TFL glute min to overwork. They all show the same innervation, the superior gluteal nerve. So you have the superior gluteal nerve innervating gluteus minimus, gluteus medius, and TFL. So they all work as a group. So I treat them as a group. And then I add piriformis for the reasons I just said. So when you find someone with pain over the greater trochanter, very often, if you treat correctly and you get to the right depth to release the gluteus minimus, they are 100% better after one visit most of the time, even if they're over 60 or 70. And sometimes it might take 2 visits to reset those muscles and relieve that pain. I'm not even going to qualify and say they may need multiple treatments. I'm going to say most of the time, 1 or 2 visits, if you do it correctly and you get to the right depth, you will release the gluteus minimus and relieve that pain. It can be a chronic pain. It can be a chronic hip pain, years, that you can resolve in 1 treatment, sometimes 2. So give that a try. And you don't need to put needles all around the bursa or anything extra for that pain over the greater trochanter. Now, I have seen where the greater trochanter is still having pain caused by tension in the IT band vastus lateralis. So I will say that if after your treatment for greater trochanteric pain syndrome, there is still pain while you're still in the treatment room with that person, then consider treating the vastus lateralis and throw in the biceps femoris to take more tension off of the IT band. That would be the exception, but that's still the same treatment, and you will have relieved years of pain for this person. I see it all the time. So I'm going to wrap it up there. I can tell I'm getting more hoarse as I talk, but consider going to live seminars. You need to support people who are out there trying to help our community to do better. And, you need to stop thinking that everything can be done on Zoom. It can't. So think about it. Look into some live seminars in an area that you are willing to travel, and consider signing up. You need to support the people who are doing it, And you need to realize that you need your hands on people to get good at what we're doing. You can't learn it all from video. So, end of rant. Have a great week. I will talk to you soon.